my philosophy is to have uncomplicated healing of the fracture as far as this super specialty is concerned. Hence, I anticipate how best to deliver the best, how best to achieve the best. I have now more than 30 years of experience, and how best to prevent complications. And the knowledge of this super specialty is very important for all of us and the learners, because whenever a workshop is held, a novice comes, does cadaveric dissection or operates on bone models, gets confidence that he will operate, but he does a lot of mistakes. A surgeon called me, "Sir, can you help me?" I said, "What's the problem?" "Sir, I'm operating upon a case of acetabulum. I'm not able to reduce it. And I am going to close it and sending the patient to you." Okay, what happened actually? So this is a 45 days old case, and I'm not able to move it. So it's an art. And a learner must assist at least for a pretty long time a capable, competent, trained surgeon to learn the acetabular fracture. That is why I have put the word my philosophy to treat such entity. And we all know that to achieve precise, stable, anatomical congruous reduction is the aim, but you cannot achieve it every time. You don't know the duration of the patient. So you look into the age, sex, what is the weight likely to have EVT, obese patients, elderly patients. Feel the pulses. Elderly patients are atherosclerotic. There could be comorbidities, diabetes. Fracture could be isolated or could be a part of polytrauma. Alimentary fractures have good results, but not the associated one. And incidence of avascular necrosis is much more when it is associated with dislocation. So all these factors have to be looked into. Fracture can be of early onset, which is between 1 to 18 days, I should say. And it can be neglected. And Judith says, he writes, in fact, it is impossible to reduce a fracture acetabulum of duration more than 3 months. Impossible to reduce. So in such a case, I will straight away go for a THR or other modality to give him a pain-free, stable, mobile hip when fracture is more than 3 months old, depending upon his age and requirements. You see, this is a cavity lesion. Defect is more than 2.5 centimeter. Patient is young. I have done a THR. Stable, fracture. Am I audible well?
Yeah, sir. Audible.
And you see, this is, I did it 2007. And range of motion, just tell you, and this is after 12 years. So neglected fractures more than 3 months, look for other modalities. I look for a THR in this patient. Do a good clinical evaluation and radiological evaluation. Clinical evaluation means must look for sciatic nerve. It's a medical legal issue. Don't forget it. Must look for pulses, posterior tibial artery, femoral artery. Never depend upon the vascular surgeon. This is my experience. Whenever you find a vascular injury, don't depend upon the vascular surgeon. His attitude is only to repair the arteries. But veins are very important as far as the pelvic fracture and several fractures are concerned. You will not repair the vein, and there can be some kind of a complication further. So do a good clinical examination and then have 3 views and CT. Take good history. Patient could be an epileptic, so he can have seizure. You operated, done the reconstruction, he gets a fit, and all your reconstructed composite which we have achieved can be disturbed. He can be a patient of head injury. And alcoholic, don't forget. These alcoholics have withdrawal. And I have come across 3-4 patients of alcoholic and head injury patients in whom the reconstruction was done, but they had delirium postoperatively and everything was disturbed. So take the psychiatrist in confidence in these patients, particularly who is an alcoholic, so that he doesn't get these kinds of seizures or fits. Now, this is a patient, 60 years male, epileptic, diabetic, 20 days old, professor of forensic medicine. In my institution, when I was away to conference in Bangalore, you see, and this is the period when these patients suffer because surgeons are not available. And he had a seizure, he had surgical knock of humerus fracture, and with 2 seizures, he had this acetabular fractures. And we found that his vessels were atherosclerotic, but postoperatively, not before that. You see here, we did the reconstruction. This is 3D. Some more images. And you find here his anterior column with the quadrilateral plate had gone. And we did the reconstruction for this patient. But on 3rd day, this patient had foot drop. And I did not remember whether the nerve injury was before the injury or it was after that. But on 7th day or 6th day, we found that he developed gangrene of the big toe. So very, very awkward position for the surgeon when a professor in his own institution, whom you have operated upon, is likely to undergo amputation. So I took you see, these are the gangrenous changes on the toes. So I talked to my cardiothoracic surgeon and he came to my help. And you see the atherosclerotic vessels, other side also. So he put a synthetic graft between the 2 side arteries and the circulation restored. So that is a synthetic graft. And that shows the peroperative pictures. So that's the importance of looking into the comorbidities and neurovascular status of the patient preoperatively as well as after that. You find there is full recovery. This is shoulder and this is at 64 weeks. Must look for the presence of screws in CT sections. There may not be any intra-articular penetration. That's very important for all the surgeons. And you see here, this is 180 weeks and fully recovered as far as the nerve is concerned. He is dorsiflexing here and the vessels are concerned. This is 7 years. Now again, I'm going to call him for his follow-up. So 3 views are a must when you study the radiology. Most of the pattern, what is the extent you can study, but CT is still good to see the presence of intra-articular cartilaginous bodies in the joint, extent of fracture, and for better classification into the various types. So these are the elementary fractures. One must know these are the associated fractures. Prognosis may not be that good as for isolated elementary fractures. You must remember. And you must know whenever there is a pure posterior column, 2 things are likely to happen. Preoperative shut-in of palsy. That is what I have emphasized. And you must be careful when you are in the region of the greater sciatic notch while stabilizing this fracture, because superior gluteal artery can be injured and you must anticipate it on CT, particularly when the patient is of 2 weeks duration, 3 weeks duration. You may get massive callus formation. That is the indication that there is injury to the gluteal artery and you should be careful. Otherwise, there will be a massive bleeding, uncontrollable, I should say. And an answer in such a case is packing and open the wound after 28, 24 or 48 hours. So 2 options are left to us now: operate or treat the patient conservatively. And third, I have told you after 3 months, the THR, arthroplasty. So when there is a loose body in the joint, as you find here in the weight-bearing dome, there is arthritis for this patient. The answer is surgery. You have to remove this osteochondral fragment and give him a congruous, stable reduction. This patient has pain. See from our attitude. There can be associated Pipkin fracture, head of the femur. Again, answer is open reduction in these patients. When the head has gone medially, there is a medial subluxation or dislocation, and you cannot reduce it. Again, the answer is open reduction. When the wall is broken by more than 50% of its length, so see, this is a major chunk of posterior wall. Again, you have to give her stable reduction. So answer is again, ORIF, that is open reduction internal fixation. When the wall has gone, inferior wall has gone into the socket, you find here, this is narrow, but here the inferior wall has gone into the socket, and yeah, again, in such a situation, answer is surgery. When this is, you find on anterior posterior radiological view that there's a big loose body, again, you can see it on plain radiographs. You have to operate upon these patients. On CT, you can find the CT is very important in these situations to see the positioning of the loose bodies, whether lying anteriorly or in the fossa or posteriorly. It is unstable fracture. In spite of traction, the head remains posteriorly. It's a shams reduction, which we say. And again, these patients require open reduction internal fixation. So we studied about 72 patients who were discharged from the ward with duration of 2 years to 35 years. That what happened to those patients who were treated, who were not operated and were sent home because of reasons not in my hands. And we came across certain interesting findings. And I tell you that in majority of the cases, 75% of the patients, all these patients can be treated conservatively. There is no indication of surgery in 75% of the patients. And indications I have already told you where you should go in for open reduction and internal fixation. So look for three things. I look for three things immediately when I see the X-ray, AP, operator oblique view. What is the status of the weight-bearing dome? The results are excellent if weight-bearing dome is intact. Generally, you can see in both column fractures. What is the status of the joint? Is it congruent? And what is the degree of displacements? If displacement is more than 3 millimeter, maybe you may have to go in. But still, these fractures can be reduced by traction also. And I will show you my cases. So with this much of experience, I have become more of a conservative surgeon. And I operate less and less. And I operate more and more of difficult cases, like the Pipkin types and other types, or the non-unions. So you see here, it was a both column fracture, 1973, and this is the follow-up of 35 years. That also shows that myositis ossificans can still form even if you treat the patient conservatively. Now, both column fracture you find here, there is a displacement, but some part of the osteochondral congruity you find here, even though the head has gone medially, these patients have excellent function, except that some abduction might be limited in these patients, but 75% of the patients can be treated conservatively by achieving congruous reduction. And that is what you see in this patient. There is a congruity being achieved. And you see on CT also in 3D. And here you find 130 weeks. It's a beautiful skill. Again, you find myositis can be formed, ectopic bone formation, even if you treat the patient conservatively. It's not that it's always formed by operative fixation. And you see the result in this patient. So when the fracture is juxtatactal, result is still good. But when the fracture is transtectal and is displaced. Transtectal displaced fracture. And you find a V sign. My paper is published this in IJO and people are following it. The answer is open reduction, internal fixation. Now this is juxtatectal, so conservatively treated. But here you find there's a V sign. There is loss of parallelism of the joint. Loss of parallelism of the joint. And even if you give him traction for 10 weeks, because he was given at home, he was discharged from the ward because of any reason, the congruity could not be maintained. And this patient resulted in arthritis. See at 6 months, Harris score 64, and he walks only with a stick. So when there is a loss of parallelism and you find V sign, the answer is open reduction and internal fixation. Again, for the learner, that is my philosophy and how I have developed myself as a pelvic acetabular surgeon. See at 6 months, the V sign persists. It's a transtectal fracture. But if congruency is maintained, go ahead with conservative management. Even in CT, you find that that's the V sign. This is the articular cartilage, and this is the head. See here, again. Now this patient, you see the head is depressed. It's not congruous here. It's not congruous here. I called this patient yesterday. Depressed here, but something is here. Maybe depression is not total. So in these cases, the CT section is very important. That is this depression in the weight-bearing dome, then you have to elevate it. If it is away from the weight-bearing dome, such patients can still be treated conservatively. So CT has a very importance. You find the degree of displacement. Somehow this patient suffered from psoriasis. I would have gone for surgery, but he suffered from psoriasis. So I thought of treating him conservatively. And you find here, this is the result after 12 years. I called him yesterday. Absolutely, you find that kind of depression also, but seems some good fibrous tissues formed from here, and here you can find that the joint is actually congruous. It may not jump into this pocket. So even if a part of the weight-bearing dome is depressed, but major part is aligned to form parallelism, such patients can again be treated conservatively. That's other view. You find here the depression, but this much, you see, this is the congruity for this patient, and that is the depression. So that's the operator view, and you find the function. After 12 years, he is jumping. He was very happy. Go up the stairs, go down the stairs. And I called him specifically to prepare myself for this lecture, which you people have been kind to allot it to me to talk on my philosophy, how I go ahead to treat these patients. I have come across all complications. In the KL approach, are you going to make a floppy lateral position? Or you are going to put the patient in prone position, because Jude himself, Mata, all those people treat in prone position. But when there is a osteochondral fragment, head is displaced, it is lying anteriorly, you cannot flex the hip. This hip in prone position is fixed in extension. So you have to go for a flip osteotomy and then go dislocate it further and remove this loose body. So the best answer as far as positioning of this patient is concerned and approach is concerned, KL approach with the floppy lateral position with the flip osteotomy, not the prone position. So these are the decisions which matter to a surgeon. So here again, look for the corona mortis when you're going from the Stropa's approach. And sometimes you may you may find some abnormality, and actually what is this artery, this femoral artery above external iliac vein. External iliac vein is damaged actually after the injury, because you do not come across vessels when you go from the stopper, and there can be a big confusion. So surgeons should be alert here. And if you find that there was a tear in the external iliac vein, you call for the vascular surgeon. This requires a repair. And if he says, no, no, there is no need, so don't believe him. Don't believe him. Call your colleague. The plastic surgeons are the best surgeons, and must repair the vein. Must repair the vein. The level also matters where it is injured. If it is below, this doesn't matter. If it is above the rim, this matters, and patient can suffer. So again, I am giving you a word of my advice because of my experience, the listeners. And the other thing, when I go for open reduction, I make up my mind how minimal invasive conveniently I can achieve. So you must go for indirect reduction techniques. Do minimal soft tissue deprivation from the bones. You see here, up to 2.5 centimeter of the gap can be created at the joint level, and this loose body, which is big one, can be removed just by using a distractor which you find here. So you must use your tools to have indirect reduction techniques in these patients to have a biological reduction and fixation. That's a posterior column fracture. And you find here, this is the posterior wall, and here I have reduced it. Dislocation, point reduction forceps, you see this fracture line, indirect reduction of the anterior column or a gesture or a transductal fracture. These are the forceps you find here. Fractures reduced. Pelvic reduction forceps, the best to reduce a patient with delayed presentation of more than 3 weeks and all those things. And here again, must see the congruity and reduction under image, because every center has the facility of an C-arm in this hospital. Must elevate the depressed fragment. So this is the head, this is the articular cartilage, and this is the gap, because I have elevated this fragment A, and B are the bone fragments. So to have a stable convex reduction, the depressed fragment of the part is to be filled with bone grafts, which can be taken from the trochanteric area. So this is a head, this is a pubic bone, and this is the iliac bone. So you can use point reduction forceps to reduce it. See here. So that is the fracture which is reduced anatomically by point reduction forceps, and then you can insert your screws. I have innovated my own scale approach, and this is called as Magu Joston approach. I don't divide the rotators, so how minimal I can be, but this is again a matter of experience. When a learner has done hundreds of cases using KL approach, conventional one, then he should think of, yes, now I have the confidence enough and I can go ahead to do minimal approach. You find here the head, that is the fracture surface. This is piriformis muscle. So no muscle is divided, and you find here we have fixed this fracture. Without dividing the rotators, I elevate the rotators like this. So this is again one approach which you can learn with experience and apply your philosophy how best you can do it. This is 5 years old, this is my callus. So I did the anterior and the modified posterior approach. You find here the head. That's the pubic bone, that's the fracture. And that's the osteotomized iliac crest. And here I fixed it. And you find here he can squat, full range of motion. This is other patient. It's a complex fracture, which again used with combined approaches. You see, that's the quadrilateral plate after the close reduction of the dislocated head. 3D, and you find this is everted. Some soft tissue is there, and that's the beauty. No, this is the only interval. I operated posteriorly. There's the anterior approach to fix the anterior column. And you find the congruency of this patient. And see, every screw is out and the joint is congruous. So post-operative CT is important, these sections, to see that there is no screw inside the joint. And that's the range of motion, 150 weeks. And that's at 6 years. Now I have more follow-up these patients. See this again, posterior anterior column, posterior hemitransfer. This is posterior hemitransfers. And I did only the posterior approach. Here, this no muscle is divided. No muscle is divided here, you see. And that's the hematoma in the posterior column. And sciatic buttress, anterior column. And you see, just using this 4-base clamp, I have reduced the posterior hemitransverse part. And these are the muscles not divided, and I have inserted the plate under the muscles. So no damage, no myositis ossificans. You see here in these patients, 16 months, no myositis ossificans and congruous reduction. So your confidence, your experience makes your policies, makes you wise how best you can deliver the best, how best you can achieve your best, and how best you can prevent the complications. This is after 4 years, the same patient, no myositis, minimal invasive posterior approach, anterior column and posterior hemitransfers. And should I thank you with this? Thank you very much. I'm grateful to you.